Hi friends, this is Dr. Ravi Kamampalai. I'm an infectious disease, wound care and obesity medicine board certified physician coming to you through this video on this pressing topic of infection that is becoming a significant problem. And I just want to disclose my conflicts of interest, nothing but removing barriers to healing. But I've been working for the last 5 years on a telemedicine solution for obesity, diabetes, and wound healing, along with my passion for removing barriers to healing. So I just want to go into present regarding this COVID infection and what might be a simple solution also for this. So the learning objective is to try to understand what this overview of quickly about coronavirus symptoms and then comparison to influenza and spectrum of the disease, along with proposed receptor mechanisms and current strategies at identification, and also some treatment options, which most of them have not completely developed proven therapies, and the secret option that I'll be talking about. In fact, we were born with that. So, coronavirus, there is 4 genera of this coronavirus: alpha, beta, gamma, and delta. Before COVID-19, that is the coronavirus 2 was detected, so COVID-2 was renamed, we had only 6 known coronaviruses in human beings, with the beta genera is the one that caused most of the infections, but also in alpha genera, basically there were 2, and one of them did cause some pneumonia and pneumonitis. So gamma and delta for now are in animal viruses only, except there is like some other viruses can cause, like MERS can cause animal infections too. But here, they were first discovered in 1960s. They were noted to be associated to happen with common cold and pneumonia and other viral infections. But SARS-CoV-1 or SARS-CoV was detected in 2002, and it caused some pneumonia and bronchitis. But amazingly, later we also found out other human viruses, including MERS and basically another virus called HKU1, which caused pneumonia like syndrome in 2005. But then it so happens that I happened to recently come across this similar genera of coronavirus that was detected because of this pandemic after we started looking more closely. And you know about MERS, which happened in 2012 in Arabian Peninsula. So this virus is a small virus with around 25 to 36,000 genes, and when compared to the influenza virus, which you have a picture here, courtesy of CDC, this virus is a little bit larger one, and we need to understand the difference between the virus and the disease. The virus is SARS-CoV-2 and the disease is COVID-19. So that is a significant difference you have to understand in the naming process. It's like you have HIV and AIDS. So HIV virus, and then that's causing AIDS, similar to that. So you need to understand also these receptors, the E, S, and M protein. And S protein, which is present on this, is being targeted mostly for the therapies now. So the problem with this virus was detected around December 31st, and WHO announced it then, and Chinese authorities identified that, and again it was named as 2019 novel coronavirus, and then changed it over to SARS-CoV. And the things started getting worse. And as you can see with the spike here over the timeline, uh, initially there was a lag in the response, but some identification processes was changed, and so the cases in mainland China increased. And then now it has been declared as a pandemic. And as of today, that is a recording on 3/15/2020, across the world there is 152,000 cases, with nearly 3,000 of them being in America. And it so happens that in China, the peak has been reached, and hopefully they are in the downward trend. So, what happens when anybody could get infected with this coronavirus? It'll mostly look like a common cold virus, but then the symptoms can be compared to a seasonal flu and common cold. But a major differentiator here is, along with the fever, the cough is a dry cough with muscle aches and fatigue, similar to flu. But here, the incubation period is thought to be within 11 to varying up to 14 days. And then, of course, there is a problem with asymptomatic patients being able to become the shredders of this. And more so, it is seen when there is a more volume of exposure, such as that happens with sneezing directly, hugging, kissing, and healthcare workers who are more at risk. Particularly more important with my presentation, what I want to bring to the focus is the at-risk group, which is diabetes, hypertension, immunodeficiency, and immunocompromised patients. So I think the problem with Italy was a lot of hugging when people meet and greet each other, and that is another significant thing that I want to bring to the forefront. So transmission, it can happen with contact, it can happen with droplets, and also there's noted to be some fecal-oral transmission and possibly airborne transmission too. And basically, we have to do airborne isolation with negative flow. And at this point, personal protective equipment is very much needed in healthcare more so. And also hand hygiene and environmental disinfection with regular environmental disinfectants are good enough at this point. So the comparison wise, this is a comparison between the flu, cold virus, and coronavirus, whereas this is very important. One simple thing wherein you have coronavirus causing usually dry cough, along with other symptoms that can happen. One approach might be to prevent you getting dry throat. Maybe warm water, like lukewarm water drinking, might be a significant approach to this, along with the hand hygiene techniques, which we are going to talk. So basically, dry cough with associated fever might be significantly important, particularly if you have attended a group meeting, or if you got exposed to somebody who has come from the at-risk places. So we are worried about SARS, but more so we should be worried about flu. As you can see here, there is more flu infections and also hospitalizations, along with increased death. That shows that flu is more significant, and we have been not paying attention to problems with influenza infections all the while. And also we have been fortunate enough to have flu vaccinations, and the compliance with flu vaccinations might hopefully increase. And particularly with this exposure, I think the flu deaths might be going down, hopefully. As you can see here, as of February 29th, 2020, 34 million flu illnesses have been there, and hospitalizations of around 350,000 and 20,000 deaths. When compared to that, you see that SARS here in 2002, it has a death rate of 9.6. MERS had 34% death rate, and COVID is 3.4. But hopefully the percentage will go down, and hopefully us detecting the virus faster will help that also reduce the risk of that. And basically, what we want to see is over time, initially there is always these threats of community exposure, pandemics, epidemics, And if you see, in 2001, we had this scare of anthrax, then West Nile in 2002, SARS in 2003, bird flu in 2005, swine flu in 2009, Ebola in 2014, and Zika in 2016. And I guess 2019, we have COVID 2019. So, like I said, the death rate with uh, with these respiratory viral infections with COVID is still less than when compared to SARS and MERS. So this was another study that I came across. University of Louisville published another study here showing that they compared the virus infection with community acquired virus, coronavirus, like the other one that I saw with the gender of HU1. They had endemic human coronavirus infection to compared with the infections that happened in the Wuhan province. They compared the community acquired infections. So we have to understand that these viruses do have a community acquired presence, and they compared these global endemic viruses to the viruses that occurred, particularly the SARS-CoV-2 in Wuhan, and they came up with a mortality rate of 3% that happens with community acquired coronavirus and also community acquired SARS-CoV-2. So the disease spectrum still seems to be the same, though. If you see, they have the fever, sore throat, dry cough, the same flu-like symptoms, and also GI symptoms. Then they proceed to become community acquired and ground glass opacities, and like the CAT scan evidence of small pattern opacities in the peripheries also become significant. So what is a virus and how is it causing trouble is because of the binding. So basically, the region of the spike is present on the receptor binding domain, and that mediates the interaction with the host receptor. And COVID-19 infects the cells and through the S glycoprotein on the cell membranes, and it connects to ACE2. And when it does that, it enters the cell, and then it is cleaved into S1 and S2, and S2 plays an important role in the membrane fusion. So they have noticed that it affects the ACE. It has its effects through the ACE2, but also there seems to be DPP4 mechanism for MERS-CoV. So that is being also looked at, because a lot of diabetic patients are using DPP4 inhibitors, apart from a lot of ACE2 inhibitors and ARBs that are being used for hypertension. So the proposed mechanism for now is working through to ACE2 receptors, and basically the spike proteins that are on the SARS or CoV-2, SARS, that is SARS-CoV-1 and CoV-2, basically have these proteins, spikes, and then they attach to cell factors. Basically, so COVID-2 requires the proteases and which present on the human body, and then this potential for invasion happens, and then these two are the sites, things that are being targeted for therapy as per the Cell article. So once the infection happens, the detection is done using the RT-PCR techniques, and also CAT scan evidence, wherein they found that high resolution CAT scans can help along with sensitivity, increasing the sensitivity of identifying. So the sensitivity is for these PCR techniques is around like if there are 10 patients are there, maybe you'll detect in 7, but 3 of them you might not be able to detect. So when they're trying to combine the CAT scan along with PCR technique. So this important thing, this slide it tells you that the COVID binds to ACE2, and then that inhibits this and angiotensin 2, and in turn that causes the lung injury. It so happens that the human body has ACE2 receptors not just in the lung, but also a lot of it in the heart and the GI tract, and also kidneys. But more so, it happens in there are multiple receptors in the fat cells. So after the infection, the entry happens and antigen presentation happens to the body, and then obviously the cellular immunity starts, the innate immunity. The T cells are very significant here. And then after the treatment, or if the patient survives, then B cells carry the memory. But here we have to watch and understand that once the infection happens, the cytokine storm happens. That's interleukins, and interleukin inhibitors are also being looked at. Apart from steroids, which I don't advocate, I think the interleukins might be more, interleukin inhibitors might happen to be more of a significant option to pull the patients who are infected. But there are other options that I'm going to discuss at the end that might help even prevent that. So who are the people who should be more concerned? Everybody has to be concerned and cautious because we are in a pandemic situation. And that said, infection control has to happen at every aspect of healthcare delivery. Particularly, it might be very complicated in dense population areas, and also luckily it appears that countries below the equator might have a better chance at survival because of possibly the heat, but I guess there are studies that are being done for that. But we have to understand that people who are elderly and with comorbid conditions with diabetes, hypertension, obesity are at risk. Now, why does that happen? Possibly because immune system in these patients wanes, and possibly in diabetes and hypertension, and obesity, patients end up having increased ACE2 receptors in the fat cells, and also people who have pulmonary existing COPD, people with influenza and secondary bacterial infections can happen in pre-existing conditions too. And particularly, we need to understand that when influenza infection during pandemic happened, most of the people died not because of influenza, but because of secondary bacterial infections that happened after that. The Chinese CDC found out that there is increased mortality in people with diabetes, 7.3% in diabetics when compared to 2.3. And also you have to understand that in the infection that happened in the nursing home in Washington state, out of the 100 people in the nursing home who got exposed, 13 people died. So basically in old age patients of 100 people, 13% mortality. So overall, Chinese prediction was the mortality in high risk was around 10 to 20, and that is in that ballpark range depending upon the people who got exposed to this virus in the nursing home in Washington state where there was an outbreak. So like we talked about, these are the detection strategies, RT-PCR in combination with CAT scan, but also we need to develop clinical detection tools. Of course, detection tools in the hospital is a later scenario. People should not be going to the hospital. People have to be detected outpatient. Now, the processes to detect people in outpatient is very, very much important. That's where the people, process, and technology is very much important, and removing barriers to healing of people being able to access care really has to be honed up in any healthcare scenario. So coming to the inpatient facilities, ideally we need to avoid and reschedule any procedures, limit any visitors that are going to come to see patients, and of course build up the capacity to prevent the critically ill, take care of the critically ill patients, and including alternate options for ICUs and separating the cohorting and maybe isolating the COVID patients away. So the people that are more at risk are healthcare providers, and the frontline staff and the resources have to be protected. So that is very much important. So the people, process, and technology that I talk about is depending upon the people first. The people include everybody, and that include the common man. So we have to understand that hand washing and sneeze etiquette, not even the hand around the mouth. I talk about sneezing and wearing a long sleeve shirt and sneezing into the elbow is the great sneeze etiquette that has to be followed. Now, we need to stop shaking hands. Maybe I should be careful, but I have to say that every time we shake a hand, we're transmitting bacteria from one another. So we're talking about using like using the Indian namaste with a small bow down, and it's like you're bowing to the god in the other person, or we are respecting the other person. And key is avoiding large gatherings, and also practicing social distancing, being 6 feet apart, and to prevent contagiousness, and also avoiding unnecessary travel if possible, working from home, and also helping employees not come to work if they are at home, giving them the option to be able to take care of the sick people at home or the kids that cannot go to the school. So, and preventing going to the ERs if not sick, calling ahead before you come. And also, we have to be cautious, not worry, but also be aware that we have to focus on increasing the metabolic health of the community, take care not to transmit infections from one another. Ideally, the best strategy is to improve the immune system, and one way to do that is to reverse metabolic syndrome that I'm going to talk about a little bit, but also take vitamin D. Vitamin D is deficient in almost 80 to 90% of population all around the world. Even in the temperature, even in the tropical countries, most of the people nowadays are in-house, and there is no way that they're exposing themselves to the sun and for the vitamin D to be produced. So these viruses can go in the infect and also deplete the vitamin D because it blocks the receptors of vitamin D. And also loading up on vitamin D with 50,000 international units once a week for 8 weeks and 5,000 international units every day after that is an ideal dosage that I recommend for my patients even before all this, because vitamin D is needed for almost 200 pathways of mechanisms in metabolic system. And of course, vitamin C, 500 milligrams PO BID helps fight the infection. And the target at this point has to be prevention, but also a real target has to be, along with prevention, reversal of metabolic syndrome criteria. That is very, very much important. So before reversal of metabolic syndrome, we have to identify the metabolic syndrome. The simple criteria: if you have high blood pressure, high glucose, and also waist circumference that is not normal, like waist to height ratio. If you have waist to height ratio, the waist to height ratio around the umbilicus waist measurement with height in any either inches or centimeters, if it is 0.5 or less, that is ideal. So waist to height ratio of that range has to be targeted. And basically the triglycerides, if the triglycerides are high, more than 150, or HDL that is less than 40 to 50, so these 5 criteria: blood pressure, glucose, waist to height ratio of 0.5, and the high triglycerides and the low HDL. So if you have 3 of the 5, then you have metabolic syndrome. So simple strategy: reverse that metabolic syndrome, talk to your doctor how to do that, and avoid this calorie in, calorie out thing. But there is different simple strategies that the next slide you can see to follow. So before that, I want to talk about a few things that regarding ACE inhibitors, because there is some craziness going around to stop ACE inhibitors. Right now, the recommendation at this point, even from different societies, is to continue the status quo, because if you stop ACE inhibitors, then you are not you're going to be affected by high blood pressure. So that might be more troublesome than the virus. So please continue yourself, but practice the 13 points that I showed in the last slide, and I think you'll do fine. But then you have to talk to your primary care provider, because what happens is with metabolic syndrome, your ACE receptors increase. So healthcare has taken a wrong curve and is just treating the symptoms of doing antihypertensives for ACE inhibitors. At least one good thing out of this pandemic is this made us look at how we are delivering healthcare. So maybe we need to reverse metabolic syndrome that reduces the ACE receptors that increase in these conditions with increased metabolic syndrome. Maybe that will reduce the need for taking all these medications. So in a therapeutic strategy that was followed in the hospital, one of the hospitals is in China, it was to check the absolute lymphocyte count. This is exactly what happens after infection, though. We need to focus more so before infection. So basically, there is a white cell count drop, and associated with that is fever, increased changes in the CAT scan, and viral pneumonia. Of course, then it comes down to isolation, the measures of isolation, and also simple close monitoring at this point. And there is other techniques and new drugs that are being worked on. And this is a phase 3 trial with remdesivir being done for this drug. Basically, this is a quick grant that was approved for this drug that has been already used for Ebola and Marburg and MERS and SARS. So obviously there is a positive data regarding this, and China has used another drug called favilavir, so that might be also looked at. So there are other things that are being worked on, including the vaccines to the receptors, but I don't think these are coming out for the next year or two, because the vaccine work involves a huge risk. So you don't want to increase the risk. Say, for example, respiratory syncytial virus vaccine testings in the past, when they were done, did cause some trouble. So this has to be very safely looked at before vaccines are released. So this might take 1.5 years or 2 years. So what are the factors that are very much important in this whole process is to basically understand that we have to make an accurate and early diagnosis, understand that we will not have any treatment whatsoever for the next 6 to 10 months, and the vaccine is not going to be available for 1.5 to 2 years. So at this point, prevention is the best strategy we have. And what do we have to do for that? Is to not do nothing but look at our own self, look at the guy in the mirror or the girl in the mirror or the person in the mirror, to understand that we have a huge issue. This happens because the viral factors and individual immune system factors. So the virus depends upon what type of the virus, how much of a load of infection we have, and also depending upon what the individual factors are, what are the genetics of the person, what are the T cells, how are the T cells working, and also what is the lymphocyte subset the patient has, and also the gender of the person. Males tend to have higher ACE2 receptors, so they might be at risk. And also, real importance is the nutritional status. This is what I'm focused on, and also the person's immune neuroendocrine regulation and physical status. So how does it just comes down to us understanding how does COVID-19 affect the immune system? So T cells, as you know, are the fundamental component of our adaptive immune system. And basically, in the context of this can happen in the context of both acute and chronic viral infections. So somebody has any EBV or CMV viral infection, then they might have some problems with T cells. So maybe they should be taking vitamin D. But then coming back to COVID-19, we want to understand that it mainly impacts the lymphocytes. So there is a sudden white cell drop in persons with COVID-19 infection, and especially the T cell lymphocytes, wherein now after infection, if the patient is admitted, what they are looking is something called as neutrophil to lymphocyte ratio. I think that ratio is coming to 3.3 or more, then the people are going to look at admitting them to ICU. So basically, in an acute SARS infection that happened in 2003, it was associated with severe reduction in number of T cells in the blood. And as there is basically a neutralizing antibody that is generated to S protein, and basically after the recovery, there is a memory B cells that happen. So in the SARS recovered patients, the B cell response was short-lived. So another treatment process that is being developed is the immune serology. So they are trying to see if you take a person who has recovered from the SARS infection, and they're trying to see if the serum that is taken from that person can be injected into the person who is suffering. So this kind of treatment was done in the past. So I guess we'll have to resuscitate that treatment. But the problem here is, what is the memory of the B cells? So we might have some issues there. So there is a huge importance as per the previous SARS-CoV viral infection regarding how T cells might play a significant role in the viral clearance. So like we said, T cells augmentation is very important, and that happens only when we are able to help ourselves by reducing the risk conditions and optimizing our nutritional conditions. So targeting the metabolic syndrome reversal of diabetes and hypertension is very important. And how can you do that? I mean, a simple process. Number one, keep carbs low and particularly avoid processed food. And we need to be taking nutrient dense foods. We need to have real foods, and we need to drink anything that is without sugar or fruit juices. Anything that is with juices increases the sugars. So real natural foods could be eaten that are not carb dense. We need to learn to listen to our body. We need to understand these three factors. We have to look at three factors. Basically, we have to understand what to eat, when to eat, and how much to eat. In what to eat, we have to cut carbs, prioritize protein, and fill with good fat, not the trans fat, not the vegetable oil fat. We have to then understand that we have been fasting from eons. We have to work on doing some intermittent fasting and use foods that keep us satiated, not calorie count. So we have to target our satiation. So these three, but on the top of the food, we have to understand that we have to have good sleep, reduce stress. There is no reason to be stressed about this virus. It is a simple dinky virus, and we can take care of it. Don't worry too much, and stress is a real problem, and it will help this virus. Get a little bit of sunlight. If you don't have sunlight, go out and have a sauna, and heat can kill this virus. So deep breathing with humidification, with humid heat, or going into a sauna, if might be good, but then that sauna has to be should be cleaned up between any treatments, or we have to understand that there comes the infection control again. So adequate hydration is very much important. If you are dehydrated, then you will risk increase the chance that the virus can replicate. So remember, solution to pollution is dilution. So regular exercise, not when you are having severe fevers, you need to talk to your MD. So also you need to understand that nutritional repletion is very much important. We need to have vitamin D, and understand that vitamin D helps T cells. So basically taking vitamin D is very much important, and understand that vitamin C has an antimicrobial component to it, and taking adequate vitamin D, vitamin C helps, and vitamin A, when taken, also helps with mucosal integrity, and also multivitamin once a day, and zinc and a little bit of copper also helps. So drinking in a copper glass of water, that is overnight, but also zinc sulfate is very much needed. So basically, what can happen now? I mean, like, this is a virus of the day. If you have this virus of the day that we can take care of, which we have adequately named as COVID-19, then what can happen with that? Is there going to be another viral epidemic? Is there another perfect storm out there? Is there other multiple tsunamis that are out there? What is healthcare doing? I mean, the real tsunami that we are facing in healthcare right now is a tsunami of metabolic syndrome. If we can help each person, empower each person using a high-tech, high-touch solution, which can be developed, it's easy, it's not hard at all, and that's what we're working on. I want us to, as a community, as a healthcare community, focus on personalized solution, get away from the mass medicine mindset, and try to understand the one person at a time, and try to understand that all this population-based data is very much good, but it does not give us a real answer to personalized solution for that N of one person who is exposed to a virus or who is exposed to his own unique problem. We cannot go trying to solve this because of mass medicine mindset. So we have to create high-touch solutions that empower that person to take care of himself and their family. So for that, what I'm proposing is a mindset of disease triangles. So when any disease happens, normally we are taught that the genetics are the cause. Yes, genetics are there. We are not born, we don't choose our parents, you see. We then say the genetics, then we get exposed to some environment, we live a different lifestyle, maybe we are living a lifestyle of smoking, not exercising, and we are doing jobs, and we are exposed to different environment we cannot get away from. Then I used to teach patients that, okay, you're in a bad environment, you're doing bad lifestyle, your genetics made you get the disease. But once I understood that nutrition has a huge role, then we started understanding that in around 2007 and 8, when we had an outbreak of C. difficile, then we started looking at microbiome and trying to understand microbiome. I was able to understand that fecal microbiota therapy, which I have personally done 106 of, has helped most of my patients. And also significant change in microbiome, and there is a significant understanding that viruses are a part of our system. It's called virome. So the microbiome and infectious microbes are around us, in us, on the top of us. But then how our microbes and microbiome, in the setting of changes that happen in lipidology and immunology, and all these factors end up causing this whole concept of disease triangles. And then I want us to understand that once we understand each of these, then we can remove the barriers to healing for N of one approach using people, process, creating processes, and developing technologies. So this technology could be telehealth technology, and telehealth technology with high-touch solution, wherein the providers can teach each other. I know something about infection, not everything about infection, and I know a little bit about nutrition, and I know a little bit about wound care. But the more I look around, I know that I don't know everything. So we need to get out of this approach of ostrich with head in the sand approach. We need to go about get a no ostrich approach. We need to go for root cause thinking and comprehensive care delivery processes with an approach of not looking at hole in the person, but a whole person. We have to be a lot more better than these professors who are out there trying to solve this huge healthcare problem but only looking at it from their perspective, like we are providing this siloed, amazing healthcare, but I don't think we are looking at the right thing. I want this tragedy of the pandemic at least to be an opening for healthcare to understand that the care delivery has to change, and hopefully it will, and it has to. We don't have any other approach. Thank you for your time, and namaste. Please use this technique to communicate and greet. Thank you.